who will introduce our presenter, Dr. Zajac.
Hi, guys. So, just to give some brief bio, Stephanie Zajac is the program director of the Leadership Institute at the University of Texas MD Anderson Cancer Center. She received her PhD in IO psychology or industrial organizational psychology from Rice University. And she also has earned her International Coach Federation credential as an associate certified coach or an ACC. Stephanie has over 10 years of experience working in healthcare and other high reliability organizations such as aeronautics, the armed forces, and oil and gas. Within the Leadership Institute specifically, she focuses on designing and implementing team and change enablement interventions to improve individual, team, and organizational effectiveness. She partners with academic collaborators to publish peer-reviewed articles in journals such as Group and Organization Management, Joint Commission on Quality and Patient Safety, and the Journal of the American Medical Association. So without further ado, I'll let her take over.
Thank you, Maddie, for that kind introduction. Let me bring up my slides here. You're all able to see that okay?
Yes, looks great.
So good afternoon, everyone. As Maddie said, my name is Stephanie Zajac, and I am a program director in the Leadership Institute. I wish I was the program director over the entirety of the Institute, but I'm a portion of it. I lead specifically our Team Science and Change group. And so I work at the University of Texas MD Anderson Cancer Center. My background is in industrial organizational psychology. And specifically, my focus has historically been on building high performance teams in healthcare. And then more recently, over the last 2 years, realizing that the two are very much intertwined, I've gotten into the change management space. So as she said, I help individuals, teams, and organizations adopt and sustain new ways of working, which is where I think that I overlap a little bit with D&I science. What I'd like to share with you today is a little bit of background on how we've approached team development at our institution. I want to introduce you to our team development framework, and then introduce some of the challenges I've seen in the work I've done with teams, and also highlight an example of an intervention that we've led to address one of these challenges. I know that we have a mixed audience today. I think most of you, I believe, conduct or at least interested in applied research, some for healthcare teams, and some of you may work in those teams or work with those teams. And so I'm going to share some of the applied research we've been able to do too along the way, and some frameworks for implementing team interventions as well. I have a couple of different aims, but honestly, my hope is that there's something in this talk that everybody can walk away with, whether that's a new idea for research, or even if you're working in teams, something you might try to improve a challenge that you've had in the team that you work with. So I'll first introduce our MD Anderson Team Effectiveness Framework. Then I'll present methods for diagnosing teams, so measurements, key points for developing interventions, and then I'll highlight types of teams research that can be done. I don't mind being interrupted at all, so if you've got a question or thought or want to share your experience, please feel free to interrupt me. I want to start out with a little bit of background about my role so that you can see the lens that I'm approaching team science from. The department that I work at MD Anderson is called the Leadership Institute, or LI for short. The Leadership Institute was created or started back in 2019. And when it started, its goal was to advance the practice of leadership at our institution. And over the last 6 years or so, we've grown exponentially, not only in the number of people that we have, but also in our scope and our primary goals. Today, the Leadership Institute has four primary goals, and that is to help individuals across our institution develop as leaders in the roles that they're in today, but also to help prepare them for the roles of tomorrow or the roles they might want to take in the future. Secondly, we focus on developing skills for mentoring, coaching, and teamwork to create the kind of culture where people can thrive. Next, as we know, change is a constant, enabling the culture, mindset, and skills people need to be able to adopt new ways of being. And then lastly, doing all of this while leveraging technology and tools that help people engage. And I add that last part because we do a lot of this remotely. We achieve these goals through 8 main services we offer. It would be near impossible for me to give credit to all the work my wonderful colleagues do in one slide, but we have groups devoted to mentoring, coaching, creating curriculum, performance management, and of course, Team Science and Change, which is the group that I'm the program director. So a little background about my role. I am a consultant, a coach, a developer of training, a facilitator, and an applied researcher. But first and foremost, though, I am a practitioner whose main role it is to work with teams to help them perform at the best of their ability. So everything I share with you today is through that lens. The first thing that I want to introduce you today is our team effectiveness framework that we use at the institution. This was essentially developed to capture everything that it takes to make teams tick at MD Anderson. But before I jump into the framework, let me back up for just a second and provide some foundational definitions. Now, I saw a lot of you are returning and you had Mike Rosen and some other teams researchers too, so you're probably familiar with this. But in teams research, a team is defined as 2 or more people who work interdependently in specialized roles toward a shared goal. That interdependence piece is what really distinguishes a team from a group. Team members have to rely on each other in some way to get work done. That's what makes it so hard to work in a team. Teamwork can be defined as the thoughts, feelings, and behaviors among team members while they work toward a common goal. So you'll hear that a lot, thoughts, feelings, and behaviors, or sometimes called the ABCs. And what that is A, attitudes. So this is the way that team members feel while they're doing their work. So it refers to things like positive intent, having confidence in the work that you do, mutual respect, cohesion, morale, those types of things. Behaviors refer to the way the team actually interacts or processes together, things like decision-making, conflict management. And then cognitions or thoughts include the way teams think. So things like shared mental models or a shared understanding of the situation. But the main point here is to distinguish between teamwork and task work. So task work is the technical knowledge and skills that you need to complete your own individual role, like financial acumen or data analysis, or whatever technical things you need to do your job. Whereas teamwork, on the other hand, are the skills you need to work with others. So how you coordinate all of that individual expertise to reach shared goals. So teamwork and task work are 2 separate sets of skills everyone needs to be able to be successful on a team. And so what I'm talking about today specifically is teamwork. The definition of a team sounds simple, but that actually gets at one of the core methodological challenges in studying teams, especially when you're talking about very dynamic settings like healthcare. And that is, who is actually on this team that I study? There are a lot of complexities that make this a difficult question in healthcare. First, if you're talking about clinical teams, definitely team composition shifts constantly due to shift changes, handoffs, rotating trainees through different areas. What looks like the team at 8 a.m. may not be that same group of individuals at 4 p.m. So you've got really fluid membership in healthcare teams. Many healthcare teams also are not geolocated. They operate across time and space. So for example, a hospitalist, a case manager, and a social worker, all very important in navigating that patient through the hospital, but rarely are the traditional bounded face-to-face team where they work together every day. And then this one I always find interesting. When asked, individuals often don't agree who's on their team, so they have a difficult time identifying the team themselves. So for instance, a nurse, you might ask them, who do you think is on your team? And they might identify with their shift group for that day. Whereas a physician might identify the team they round with for that day. So even the folks that work in these teams sometimes have trouble defining who exactly is on them. And that lack of a shared team identity really complicates any data collection. That is definitely one of the biggest challenges as a teams researcher. So what you have to do if you're interested in studying teams is choose a factor that you're going to use to define teams and make a case for it. So in a lot of the work that I do, a team is defined by their immediate leader or their reporting structure. But you could also create a team based on shared goals or how closely people work together or how much the team interacts on a day-to-day basis. So that's one of the biggest challenges that we have. But once you've defined the team, what competencies are important for this team to perform well? Again, I'm coming at it from a practical lens, so my work is mostly driven by what challenges the team is having that I'm able to help them with. But for researchers, what are you interested in studying in the team space? That's the what. And regardless of whether you're working with a team in the development space or conducting research on teams or just work at a team, it's useful to start with some sort of framework. So this is our MD Anderson team effectiveness framework, which you see here, and it serves for the basis for everything we do with teams, from designing interventions, implementing interventions, to all of our research. And importantly, and I think one of the most useful uses it has, is it serves as a common language with which we can talk about teams at the institution. So we use this when we're talking about what's challenging to a team or what help they might need. And it was built from a couple of different sources. First, in order to ensure we were creating something that was evidence-based, we drew from the research on team science. If you're unfamiliar with that literature base, it is vast and it is probably over 100 years old at this point. But we had the opportunity to partner with some colleagues from Rice University, which is right across from us, with Eduardo Salas and Scott Tannenbaum. And there are hundreds of frameworks out there, but the frameworks we drew from are represented here. There's a lot of overlap in them. I would say my piece of advice here, if you're going to do something like this, is to make it your own. So we spent a lot of time MD Andersonizing, if you will, this. And I think that's why it's been received so well at our organization. And we did that through creating a working group of leaders across MD Anderson. I personally had the opportunity to go interview teams across the clinical research administrative space, and I simply asked them, what helps you work well together with others, and what gets in your way when working with others? And then we put all of that information together to create what you see here. And that was a really important step because we ended up including some things that are really core to kind of the fabric of MD Anderson, like assume positive intent as a team attitude, which you're not going to find in the literature. And so what we came up with were the foundations of teamwork, the ABCs of teamwork, and the ideal team states. So it's built in this pyramid purposefully. The foundations of team effectiveness can be thought of as laying the groundwork for successful teamwork. So if you don't have these in place up front, it can negatively affect everything upstream. So it's purposely built like that. So for example, if you look at the foundations down there on the right, you see clear roles and purpose, you see clear roles and responsibilities. If you don't have clear roles and responsibilities on a team to start, it can quickly cause miscommunication, things falling through the cracks, duplicating work, conflict over who should be doing what. It can cause a lot of issues in this next level you see here, which is the ABCs of teamwork. And this refers to that definition I said earlier, the way teams feel, what they actually do, and the way they think. And then finally, on top of that, we have the ideal team states. We named them this because the idea is this is where you're trying to get. If everything underneath these two levels has been established, then you're operating in a space where people feel open and collaborative, where they can speak up and fully contribute, where they're adaptable to any one of the number of changes you face in healthcare every day, and they're able to bounce back and adjust. And so at the very top of it is, of course, team effectiveness, which is a term that I think we throw around a lot without identifying sometimes. So for a point of clarification, I'm really referring to three things when I'm saying, is a team effective, or things teams need to be effective. And the first is functioning, how well the team functions or works together on a day-to-day basis. The second is, of course, the results or the performance, because you can't get away from that. Are they reaching their shared goals? And the third, and the one that I think is sometimes overlooked, is team vitality. And that taps into things like morale and engagement and satisfaction working on that team. Do I want to show up and come to this team every day? Part of the reason that I love working with teams and researching teams is because we're all kind of experts in teams, right? Every one of us has worked in a team at some point in our lives. And we've had good experiences and we've had bad experiences. And what I'd love to hear from you, if you could just put in the chat as I move on here, as you look at this framework here, the foundations and the ABCs of teamwork, when you're working in teams, be it your research teams or your healthcare teams, what are the big pain points you've seen in teams that you've worked with or studied? If you could just go ahead and put that in the chat, I'd love to hear some of your thoughts. Got variability in the frequency and quality of communication, lack of trust. Yep. I do this. Shared mental models. Yep. Lack of shared values. That's a good one. Lack of team direction in foundations. Lack of agreed upon priorities. Oh, in healthcare, that is so important with so many things on everybody's plates. It's a good one. I do this little exercise mostly to show that you all are experts in teams too. You know what it takes for a team to be effective. You've worked in teams, you've worked in good teams, you've worked in bad teams. So if you're not yet a teams researcher, I think that this is a space right for people to contribute to, even if that's not their background and their training. I show this as an example of the type of research we've been able to do around our work. So I've got a couple examples throughout this presentation of manuscripts that my team has published around the work that we've done, just to show you the type of work that you can do in the team space or the type of things you can publish in the team space. This one was on that framework, and it was coupled with a diagnostic tool we created that aligns with it that I'll talk a little bit more about in a minute. And we also talked about the most common challenges we've seen in teams, which I'll highlight here shortly. But there's lots of frameworks or organizing frameworks that you can find in the literature. So once you have that common language, once you have your framework around teams, how do you define what their actual needs are? You've got teams that work in the clinical space, the research space, the administrative space. They all have very different needs and they're all at very different places of their formation. So when teams come to you for help or when you're looking to study teams, how do you figure out what are their challenges, what are their needs? Whether you're in practice or academia, you can't meaningfully work with, you certainly cannot meaningfully study teams without some form of measurement. At the Leadership Institute, measures for teamwork and team performance are integrated into our everyday practice. And they're integrated in 3 different ways. The first is part of our team development services, so my team. Part of our role is focused on working with teams across the institution, again, from research, clinical, and admin domains, to either set them up for success when they're first getting started. So you'll have new leaders call and say, hey, I just took over a new team, or I'm just forming a new team and I don't really know where to go. Can you help me set it up? Or to help manage, more commonly really, to help manage any one of the number of different challenges that can come up when people start working together. So for example of a measure in this space, I'm going to talk a lot more about this team diagnostic, or a little bit more about this team diagnostic. But as part of our team development process, we start with a measure that we call our team diagnostic. This measures, this kind of drives everything we do on the team development side. And it's based on that framework that I just showed you, 1-to-1. It has one item for each one of those competencies. We also have items, teamwork items or responses embedded within measures that serve other institutional level needs. So we've got teamwork items in our employee engagement survey. We have a culture of safety survey that has teamwork items in it. We've got an anonymous reporting system for safety events, both clinical safety and professionalism type safety events. And then lastly, we have more formal training programs for teams that we develop. They're cohort based, and they're a source of all sorts of qualitative data, from training needs analysis to simulations and interviews and focus groups. I have to say, I cannot overemphasize the importance of qualitative data when you're doing teams research. I am a quantitatively trained researcher. I think it's becoming more common for qualitative folks. I love surveys, but the context and the full picture and everything that's really going on with the team, you cannot get that without talking to people. So if you are interested in studying teams, I would say draw from both of those toolkits, both quantitative and qualitative research. Every one of these different areas you've seen, we've been able to draw from to publish and highlight our work, and to disseminate some of our best practices that we found too. So the main point is there's lots of different opportunities in the activities you might likely already be doing at your different organizations for you to embed or pull out measures of teamwork for multiple purposes. So again, just to highlight, I'll share these slides. These are some more examples of things we've been able to publish with this. One focus is solely on the development of short practical measures for teamwork. So lots of measure development papers. This one's published in actually Clinical Journal. And then the other one here used the professionalism safety incident database we have as the measurement instrument there. So lots of research you can do just solely around developing those measures. There are 4 main reasons that I could think of that we use teamwork measures. The first is, of course, for assessment and diagnosis, for baseline measurement before we do anything with a team. We assess where they are now so we can assess if we've moved the needle 3, 6, 9 months down the road. The second, and I would say probably the most important for my work, is informing interventions. So when you start working with a team, people will tell you there's all sorts of problems going on. They want better communication, or there's conflict, or whatever it may be. But these measures really help you target the competencies that are identified as a pain point and match that to an intervention that is designed to work for that competency. And then to tailor that intervention with all of that extra context the team is experiencing. The third purpose is, of course, measuring outcomes. This could look like team health checks before and after an intervention to capture shifts in their effectiveness. It could look like tying it to organizational level outcomes that leaders are interested in. And then the final one, and the one that I don't think is thought about often, is for development and coaching. So we use these assessments to then coach with team leads and help them understand their team's functioning and where they should be focusing their energy and where they might need to grow and develop as a leader. So this is a deeper look at our team diagnostic that I mentioned. Again, it has 24 questions. They map one-to-one with that framework. So there's one question for accountability, one for shared leadership, one for clear roles. And we use this specifically as part of our team development programs when we're helping teams one-on-one. We have given this survey to close to 50 separate teams across the institution in a lot of different spaces. And we looked at all of that data across the board at those responses and came up with what are the top challenges faced by our teams at our institution. And again, so these are just at our institution, but my guess would be that they generalize to some of the teams that you work in. And those top challenges are accountability, psychological safety, taking time to stop and reflect on progress as a team, adequate coaching and development for team members, decision-making, and conflict management. And our survey also gives us a little background on why these arise. We have had to tackle each one of these challenges at our institution, and I could do a whole talk just on how they arise and how we tackled them. But for the sake of brevity, psychological safety, this is influenced a lot by the hierarchical nature of medicine. So there's just some inherent power differences in the way medicine is set up. If there's a culture of fear or blame, there's really high consequences for mistakes for our clinical folks, which can affect psychological safety. Accountability, I think, is the other side of the coin from psychological safety. It's influenced by diffuse team structures or rotating membership, lack of role clarity, competing goals between folks that are both in like the clinical and academic space or the clinical administrative space, only have so much time and they have competing goals. Decision making, this one often manifests, a phrase I hear often at my institution is unclear decision space. So people are uncertain or have overlapping kind of decision authority on who moves different things forward. In our case, another struggle that we have is norms that favor consensus. So a lot of people want everybody to agree with decisions, which is wonderful if you're trying to get buy-in, but not so great if you're trying to move things forward quickly. For conflict management, I think this is partially influenced by the organizational culture. If it favors avoidance, or what I've often heard termed as a culture of niceness in some academic medical institutions, often that leads to being conflict averse. And then for coaching and development and reflecting on progress, I think they scored low. I think with busy clinical schedules and all sorts of competing priorities, as somebody mentioned earlier, things like leadership development, coaching, taking time out to pause and reflect, these things become nice to have and not necessarily a priority that's essential for high performing teams. So I do have to say a lot of times I'm having to show the value of why you would want to focus on these things through the data that we collect. So I'd encourage you to think on your team or team you're interested in studying. Think about how these might be impacting team. But once you know the challenges, how do you begin to address them through interventions? I would love to know, just out of my curiosity more than anything, can you put in the chat, have you ever been part of a team development intervention in the organizations that you work at? I'm curious to how common that is in other organizations. I'm looking at the chat here real quick. I see somebody lamenting with the pain point of who is on the team. Yes, that's a common one. Have you validated and published these measures? Yes, there's some examples in the PowerPoint slides, which I'll send out, that show where we've published and validated. Now, you have to balance the reality of practice and working in an organization with the amount of effort and time you can spend validating a measure. So there's a little give and take in that. But yes, we have. Same as team building. Oh, that is such a good question. I want to stop and address that one now. I draw a pretty clear distinction between team building and team development. Not that they don't both have their time and place, but team building is usually one-off events that are designed to make you feel good and connected to your team and increase morale, and give you a space to talk and interact with your teammates. So again, very much needed and important. But team development is helping that team form, storm, norm, perform, complete their goals, and be satisfied, engaged team members. So it's much more about targeting those pain points that teams need to be successful in their roles, and less about just being connected to your team members and increasing morale. I hope that is a clear explanation, but those are definitely two very different things. Lacerenza et al. 2018 does a great job explaining the difference of those if you're interested in that. Alyssa says, as a school psychologist who has worked on a ton of teams in school, research, and medical settings, I've sadly never been a part of team intervention. That is sad. Yes. Okay. Our hospital system requires everyone to take a webinar on teamwork. It's not great. Oh, okay. I talk a little bit about that in the intervention side of things. I do think there's a time and a place for virtual education, even if it is on teamwork, but it's usually to create a baseline understanding and get you familiar with common terms. It's not going to teach you necessarily skills how to work well with others. We don't do too many team development interventions in academia, that's right. Okay, so some, but not many. So I'm going to talk a little bit about how I develop interventions with the example of psychological safety, because this is something that we recently tackled at our institution. I would imagine there are a lot of frameworks or ways that you could organize and think about how you can approach interventions for team development. But when I stopped and spent some time thinking about how I approach them, I was able to break it into 4 categories. And that is the focus area, or the what. What's the challenge or the pain point or the problem I'm solving for? The mode of engagement. So depending on the what, how should I be engaging with the team? If I'm tackling communication, what's the best way to do that? Not with a webinar. The level of intervention. So is this going to be something that I'm going to be doing a one-time event for? Or is this something I'm going to want to be spending more time with the team over? Sorry, that's the depth and duration. And then the final one is the level of intervention. So is this something at the individual, the team, or the organizational level? And so I'll give you an example for that one. Our team effectiveness assessment, let's say you're using our team effectiveness assessment, and it might highlight that there's a communication challenge on the team. Let's say you take that assessment, it says there's a communication challenge. There are so many different levels at which that could manifest itself. So the challenge might lie with the leader. So for example, maybe they have a very direct communication style that isn't interacting well with the preference of their team members. Or maybe it lies with the team as a whole. Maybe they don't have the right tools to communicate, or they don't have the right skills to resolve conflict. Or maybe it's even at the organizational level. Maybe there's a lack of strategic alignment in communication, where the operations office is, for example, emphasizing the importance of patient safety and patient care, and the finance department is emphasizing productivity targets, and middle managers don't know how to reconcile and communicate that to their teams. So there's so many different reasons or layers on where that problem might originate. Going back to the how for a second, I want to make sure I touch on each one of these. Here you're trying to make sure the intervention is delivered in a way that's effective and engaging for that team. So common methods I use include facilitation. So where I'm facilitating sessions, these are things like workshops, retreats, team launch sessions, charters. Coaching is another intervention that's like ongoing coaching sessions with the team or the leader. Training is more formal training, structured skill building. Consultation is meeting one-on-one with the team leader and helping them solve their own problems, essentially. And then structural design is system level interventions that you're looking at. And so when I'm thinking about team interventions, that's the framework that I use. The what, the how, the where, and the when. I thought I would try to bring this framework to life for developing interventions with an example of work that we've done, like I said, with psychological safety. So that's what I'm going to talk about for the rest of the time. I think this is an important one. Let me ask again. I'm just curious in the chat. Who has anybody heard of the term psychological safety? Just yes or no? Yes, yes, yes. Okay, that's great. Familiar with Edmondson's work? Yes, she is kind of the founder of all that. Okay, great. So everybody's familiar with it. Just to go back, because I don't want to miss the question in the chat, the applicability of team development interventions in team science for community academic partnerships. Yes, there definitely is. There's actually a whole sub-branch of team science called the science of team science. Gotta love science researchers, or teams researchers, but that's specifically on academic teams and how they partner with different communities. So I can find a seminal paper and I will send that out with this PowerPoint. Okay, so everybody knows what psychological safety is. In the healthcare literature, it's very much been established as important to team performance, patient safety, staff well-being, and a whole host of different outcomes. So I think this is relevant regardless of where you're working. The what or the case for change when it comes to psychological safety for us, for our organization, came in part from the results of our recent safety culture and engagement survey. So while MD Anderson as a whole exceeded top quartile national benchmarks, psychological safety was still one of our lowest scoring categories, so something we wanted to improve. And our leadership really understood how fundamental safety was to creating a culture of continuous learning, of innovation, of improvement. So luckily they were very much behind intervening to improve this measure. So these were a couple points of data from the institutional level measurement tools that we had to help create the case for change. But then also we have a survey that we use specifically within the Leadership Institute, and specifically that I use when I work with teams, that is part of our team development efforts. And it is based straight from Amy Edmondson's work. It's got questions around mistakes not being held against you, around members of the team being able to bring up tough issues. And then it has 2 open-ended questions about what facilitates or impedes psychological safety. And so to further inform the what, we were able to take all of those open-ended questions. Again, it was well over 50 teams that we've given it to at this point. And we came up with factors at the individual, the team, and the organizational level that people said affects their ability to speak up in healthcare teams. So this further informed the potential intervention that we ended up going with. And we were able to publish this work as well. And this was a qualitative paper. The data told us, we saw the organizational level engagement survey data. We saw the data we were using for team development interventions. And so this told us that this was more of a systemic challenge or opportunity. And we chose to intervene at all 3 levels. So I would say it's on the rare side that we put this amount of energy and effort to intervene at all 3 levels, but for this one we did. So we had interventions at the individual, team, and the organizational level. We wanted to do something at the individual level, just to give you an idea of our thought process, because we know that the leader plays a big role in creating a safe environment. The literature, the science tells us that their behavior, their mindset, their leadership style strongly influences how safe others feel to speak up. At the team level, we know that psychological safety is an emergent state that is a result of everybody's shared experience. It lives in the interactions and the norms and kind of the level of trust in between team members. So that was important too. And then we also know at the system level, people talked a lot about organizational policies, a lot about anonymous reporting systems and the culture of the organization. These impact psychological safety too. So it had to be kind of this top-down and bottom-up approach. And so we knew to truly move the needle, we needed to act at each one of these levels. For the when or the depth and the duration of the intervention, given everything I just shared, it was pretty easily decided that this would require a deeper, longer dive. For a couple reasons though. One, anytime your intervention involves behavior change, you all know this, that takes time. You're looking at shifting some pretty hardwired behaviors and attitudes, which are shaped sometimes by years of previous experience. It's funny, sometimes I will talk to folks in one-on-one interviews and talk to them about why they might feel less psychologically safe, and they recount to me experiences of a leader who may have brought out a mistake that they made publicly in a meeting, or had some other repercussion, and you're talking to them and it sounds like this happened yesterday, and in reality this was like 5 years ago. So people really hold on to that, and it takes a while to change behavior. We also know that culture shifts gradually. Again, one session won't address something that took years to develop. Leaders have to model safe behavior consistently over time. And then, as is the case with a lot of things in team development, progress is not always linear, unfortunately. We fully expected that as people learned more about what psychological safety is, started talking about it, started unearthing maybe issues they hadn't thought of or talked about for a while, we may actually regress a little bit in some of these measures. And so for that reason, we decided to do this intervention over time. So this was something that we as an institution committed to working on over several years. The final part, the how the intervention details, is why you choose different modes of engagement depending on the topic, goals, or the context of the situation. So this is what the intervention actually looked like. Because psychological safety is this emergent state that arises from multiple factors, we actually used several of these modes of engagement. We used facilitation. A lot of times in teams topics, but especially psychological safety, a neutral third party helps reduce kind of that inherent power dynamic between the different medical roles. It helps surface tough issues that team otherwise maybe wouldn't talk about. You can kind of encourage participation from all. So we used a lot of that. In this particular instance, the interventions we used were facilitated team norms workshops And then we also debriefed a lot of folks on their engagement survey data. We used training. I know I talked about the limitations of training, and especially virtual training, but I do think it helps build baseline knowledge around what psychological safety is. It can help build a common language across the institution, so you can start having those difficult conversations. So here we used instructor-led courses. Some were virtual, some were in person, and they were available to all staff and all leaders across the organization. We had special sessions for leaders whose areas scored particularly low on the employee engagement surveys. And we used simulations to give them a chance to practice these new skills. And so that, I think, was a really valuable mode of engaging. People learned a lot there. And then we even had Amy Edmondson come speak at the organization. So again, she's the researcher who really pioneered the research on this. She came and talked at MD Anderson, and it was received very well. We used coaching. We're still doing this actually, and specifically group coaching. So we took the different topics from the survey I just showed, that qualitative survey that looked at the factors affecting psychological safety, things like communication, dynamics, trust. And we held group coaching sessions with leaders across the institution so they could learn from and with each other and share their experiences. Group coaching is a much more scalable solution than individual coaching, and people actually did learn quite a lot from each other during that. And then finally, we made some structural changes at the organizational level. We worked closely with our HRO, our high reliability organization folks, to create a just culture algorithm for managing errors in a way that balances both psychological safety and accountability and reliability. And then we had safety as a core value at the institutional level already, but we added specifically psychological safety under that to emphasize the importance of this to the institution. So as you can see, we came at this from multiple angles. I wish I was giving this talk in a couple months. I'd be able to report on results of this, but we're still wrapping up these interventions. We're still completing the group coaching. As we plan for measuring outcomes, we want to do that across all 3 levels we intervened. So tools we're looking at include our Leadership 360 assessment, of course, engagement scores around psychological safety. For those teams we've worked with, resurveying with our psych safety survey, and even looking at the number and type of error reports in both our clinical and professionalism reporting systems. Although that last one's tricky because some of Amy Edmondson's work shows that error reporting actually goes up when people feel safe because they feel comfortable reporting errors. So that is how we plan on measuring those outcomes. And the development, implementation, and evaluation of interventions, as you well know, is an area ripe for publication. So we've been able to publish quite a bit of our work around that as well. So I will stop there. I was aiming for 45 minutes. I'm close. I have 10 minutes for questions. I answered some along the way, but if anybody has any questions, I would be more than happy to answer them.
Great, thanks, Stephanie. That is a really comprehensive presentation. You're really doing a lot there. Yeah, and I had typed in a thing in the chat that was like, how do you measure outcomes? So that was helpful with that last slide. But I'm wondering if you also, or if the hospital systems are looking at other employee outcomes, things like, well, I mean, the usual like job satisfaction, turnover intentions, but also the effectiveness of procedures or patient outcomes, if they're looking at that at all.
Yeah, that's a really good question. So at our Leadership Institute, we're lucky enough to have another industrial organizational psychologist working in our research and analytics wing, and she does pull things like satisfaction, and turnover intentions is often an outcome we use, which I think would be great for this one. I hadn't really thought about the clinical outcomes as much, but I do think that would be a good one as far as like an ROI that the organization really cares about. So I will. We're planning the evaluation now to be transparent. I will definitely see if there's a way to include that because I think that's a great idea. Thank you. Especially in the areas that scored lower, because we do an engagement survey every 2 years, and in the off years we still have psychological safety in our pulse check survey, so we could see who scored low and if it went up, and then does that tie to clinical outcomes, which would be awesome.
Stephanie, I have 2 questions. I'll pose both of them, but I don't want to hog all of your time. So you can maybe choose the one that you like the best. Um, so my first question is related to outcomes. I'm wondering if you have thought about using or are planning to use any ethnographic measures to assess psych safety. So, for example, in team huddles, as a result of some of these team development interventions, are people more willing to speak up, kind of share their ideas, push back on how procedures or certain processes might be conducted? So that's one question. And then second one, just selfishly, I'm trying to craft a TDI for increasing depression screening across different medical settings. And a struggle that I'm working with is that oftentimes an individual may feel like they're a part of the medical team, but not part of the kind of behavioral health team. And so they're sort of straddling worlds. So more just pragmatically, do you have some kind of secret or key ingredients for implementing some of these TDIs? Many of them that you described sound incredible, but also kind of time and resource intensive. So how do you go about implementing them in these kind of busy real world medical settings? So those are my two questions. Thanks so much.
If I can ask a follow-up question, what is the main challenge with folks that are straddling both worlds when you're trying to implement interventions?
I would, it sort of, it depends if they're inpatient versus outpatient, but I think for them individually, one of the challenges might be just competing priorities. Do I focus more on sort of the medical needs of this patient, or do I focus on the behavioral health needs of the patient? And all within my, work day.
Yeah. That's a tough one. I feel like I deal with that a lot more in my change management work. But I think that speaks to the importance of effective sponsorship when you're trying to enact behavioral change. You need somebody that those folks look to for direction clinically, that is sponsoring that effort, that is selling the why, the value, how it makes their world easier, and then be really careful about your strategic communication strategy around that. That is a tough one though. What are you going to take off my plate when you put something else on it? Is something that I hear often. To answer your other question, I think that sounds amazing. I would love to do that, but I think it's like a bandwidth issue why we haven't. You'll see like in a lot of the publications that I have, we partner with folks at different institutions, academic colleagues that I've met along my career path, and really lean on some of them and their grad students for help doing this work. It is highly encouraged that I do it, but I don't get a whole lot of my time out of my day to be publishing all the time. So that is a wonderful idea though. I think that for a future study, that might be something to look at.
I have a bunch of questions, but I'll just ask one. So I'm curious about the decision-making piece you mentioned earlier. I'm also working in teams responding to child abuse, and so thinking about who's making decisions about what and how do other people's decisions affect your decisions. I'm curious if you have any like good references or measures or just things to kind of come at it from the team decision-making angle.
As far as like interventions you can do to help that?
Any of it, like how do you measure that? How do you intervene on it? All of it. I think it really was like, oh, that's what these teams are really struggling with a lot of the time. And I hadn't really thought about it in like the decision making as like a central piece.
Yeah, at our institution, a big piece of the decision making problem is people aren't clear what their decision space is. Like, am I giving input into this? Am I recommending a decision and somebody else gets to make it? Do I really have the authority to push this forward, or do I need to go ask so and so? And so the workshops that we do around decision making is usually getting teams together and talking about just that, whether you using the rapid model of decision making or whatever kind of roles and responsibilities model you want to use, and making the space to have a conversation about it. I think that's true of a lot of these team things. Like I said earlier, you're working with brilliant people in healthcare, right? They just don't have the time and the space to step back and talk about these things with somebody who understands it in a structured way. We have a workshop we do around that too, that I would be happy to share kind of the outline with, if that would be of interest.
Yeah, that'd be great. And then if I can ask another question, I'm curious about thinking about like the time frame for evaluating effects of team interventions. If you had to pick one, knowing that, you know, teams take time to make changes, and the longer you wait, the more change and fluidity there has been in the team, and who knows what else has happened in the meantime. If you had very limited resources and you had to pick one time point after a team intervention to do a second assessment, what would you pick?
Oh, that's such a good question. Okay, there's some things in the context that I would consider, like, did they just get a new leader? Was there something major that just happened at the institution? But, or did they just get, you know, 5 new team members? But all things held constant, I would not want to measure team effectiveness again unless like 6 months passed. Because it takes time, and it's multiple sessions that you hold with these teams. So you go, you do whatever you're going to do for your intervention, you give them new things to try, new skills, new ways of working. They've got to go back and try it and come back and say, that worked, that didn't work. We want to try this moving forward. And that takes time, especially when you're working with clinical folks. They don't want to take more than like 1 session a month out of their busy schedule. So I think if you do anything before 6 months, you are not giving them enough time to move the needle to say it was successful.
Yeah, that's reassuring for our intervention that didn't find any effects 3 months later. Maybe they were still there.
Up yet. Sometimes it takes time. And you know, check in and see what's working, what's not working, and do it again in 3 months. But yeah, I do think it takes time.
So I will jump in, even though you have responded to a couple of my questions already in the chat. Thank you so much. We are building this DNI repository for measures. It's part of the DNI Models web tool. And I am just thinking very hard here, which of the top measures from this team science, team development, you know, interventions, literature we should put in there. So we might reach out separately, but I also love Anisha's comment there that are there, you know, ethnographic tools that we could include in addition to quantitative instruments?
Yeah, that's a good question. I would be happy to share any that I have. It's tough because a lot of the well-validated, you know, measures a lot of validity evidence behind them. They ask, for example, if you're measuring psychological safety, 6 questions about psychological safety. And while from a methodological standpoint, that's wonderful. From a practical standpoint, I can't ask people 6 questions about the same thing if I want to give them a 10-item survey, right? So you kind of just gotta look at the trade-offs. But I have several. I'd be happy to share anything. I will put my contact information in this as well. I love this stuff. This is what I do all day. So if anybody wants to chat further about it or has any more questions, I would be happy to answer them.
Okay, well, if there are not any more questions, we are approaching time at seconds. So if everybody just round of applause for our speaker today. Thank you so much for being here. Very great insights, lots to learn. Just for those of you who are still interested in kind of the team development and intervention space, we're in the process of launching a team development resource on the InStep website. So, and we already have some up of other team constructs, emergent states and processes, as well as lots of validated measurements of those on the InStep website. So feel free to check that out and stay posted for our team development expansion. So super excited about that.
Thank you, everyone.